30 years ago, my wife and I lived in Kenya, and I was telling the story of how we took a 5-hour bus ride to Nairobi to the IPPF affiliate family planning clinic to get family planning for her. She was examined. She was healthy. And we were told in no uncertain terms, but very politely, that she would not be getting any family planning method that day because she was not menstruating. And the reason we're here today is because every day all around the world that scene repeats itself. And for us it wasn't a big deal. It was an adventure, and we got to go to the big city. But all over the world, women take time off from their busy lives. They take long bus rides or long hikes. They do exactly what we want them to do. They go to a family planning clinic, and then for no real good reason, they are denied services because providers can't or won't rule out pregnancy if they are not menstruating the day they show up. So what's this all about anyway? It turns out that in the WHO Selected Practice Recommendations for Family Planning book, one of the most common sentences says something like, the woman can start blank immediately if it's reasonably certain she's not pregnant. And you fill in the blank with almost every family planning method there is. So providers are told that they have to rule out pregnancy for all new family planning clients. And the reason for this is simple. We don't want to give a family planning method to a woman who doesn't need it. And in the case of IUD clients, a small minority of clients, it's very important to do this to protect the health of the mother and to protect her ongoing pregnancy. So unfortunately, though, this rule about ruling out pregnancy for new family planning clients has created an ongoing physical barrier. Non-menstruating women who present for family planning are routinely denied family planning services, and this problem may be even more serious when the woman wants a LARC method, a long-acting, reversible contraceptive method, because providers are even more concerned about the woman and her health. And it's not a small problem. Depending on the setting, up to half of new family planning clients are not menstruating when they come for services. Yet, the actual truth is that very few non-menstruating clients are actually pregnant. Our research shows that it's only about 1% of these women who are actually pregnant. And it's even more, ironically perhaps, according to WHO, if the woman wants a hormonal method, there's no known risk to the woman who's using hormones to her fetus or to herself if she starts family planning when she is pregnant. So what is a conscientious provider to do? Well, the first step a provider should do is to take a medical history from the woman. And it turns out there are several questions that you can ask a woman that help rule out pregnancy, that exclude the possibility of pregnancy, at least with a reasonable degree of certainty. These questions, these criteria have been gathered together into a job aid called the Pregnancy Checklist that help a provider ask these obvious questions such as, have you had sex since your last period? Have you delivered a baby in the last week? Have you been using a contraceptive method correctly and consistently? And research has shown that using this job aid, this pregnancy checklist, is an effective way to rule out pregnancy, and also has an impact, and it allows more women to be provided the family planning method of their choice. And for these reasons, this job aid, this guidance, has been included in WHO guidance and USAID and other program guidance for family planning. However, the bad news is that there are instances when this checklist cannot exclude pregnancy, and according to our research, about 10 to 20% of the time, the pregnancy cannot be excluded because women do not meet any of these 6 criteria. So 10 to 20% of the time is not bad. That means that 80 or 90% of these non-menstruating clients can be served. However, we've found in the last 15 or 20 years since the pregnancy checklist was introduced that some providers don't like or trust the checklist. What this often means is that they don't like or trust their clients, or at least they don't trust the clients to answer these questions truthfully. So when the provider can't rule out pregnancy with a history, or when she won't rule out pregnancy with a history, the provider has to revert to either making the client wait until they have their next menses, or the other solution, which is our topic today, which is the pregnancy test, or often called a pregnancy test kit, with its characteristic thin blue line. We're not talking about the pregnancy test that you buy at PS or the Walgreens for $20 or $30, which incidentally you're really overpaying for. We're talking about a simple strip of paper that can be purchased wholesale by programs for less than a dime. And that is our topic today, and it's a very fraught topic indeed, because we're going to be discussing whether programs should be providing these tests for their clients, and in particular whether those who fund the program should be procuring these pregnancy test kits as a commodity. And understandably, the funders may be reluctant to add yet another commodity to all the commodities they're already procuring. And the program people, having invested lots of time and effort into getting the checklist out there and available and training providers about it, are concerned that if pregnancy tests are available in the clinics, that providers will not take a history, will not use the pregnancy checklist, and all that effort will have been wasted. And they're even more concerned that if providers do become dependent on these pregnancy tests, that and then the tests run out, if they have stockouts, that providers might not provide family planning at all. So we'll be discussing that today. In some cases, these fears have been exaggerated, but they're widely shared, and we'll be discussing them today as we move along. In the interest of time, I'll go ahead and talk about what the evidence shows us about what happens when pregnancy tests are provided in family planning clinics. We did some research in Zambia a few years ago where we tracked whether women who presented for services were actually provided a service, and in randomly selected clinics, we provided pre-pregnancy tests to the clinic and told them they could use it as much as they wanted and as needed. And then in another randomly selected set of clinics, we didn't do anything. And what we found at baseline was that about 15% of the non-menstruating new clients were not getting a service, but when pregnancy tests were provided, that number dropped significantly down to about 4%. For transparency's sake, I'll also mention that we tried this same study in Ghana, and we got results that were not as positive, and in fact they were nonsensical, and we still haven't figured them out. But Zambia was sort of a best case scenario about what could happen when pregnancy tests are made available free of charge to family planning clients in clinics. Another notable thing about this is that if you remember earlier, I mentioned that when providers do use the pregnancy checklist or take a history, that about 10 to 20% of clients cannot have pregnancy ruled out. So the baseline finding of about 15% of clients being declined suggests that providers are trying to do the right thing. They're not sending everybody away, but that some portion of clients were typically being told to wait or not getting what they needed. But when tests were provided, the problem was largely solved and clients got the services they needed. There are some other potential benefits of providing family planning, of providing pregnancy tests more freely in our programs. Our colleague Tim Manchester had the idea that they could be a great tool for demand generation. Why shouldn't family planning clinics actually market free pregnancy testing and use that as a way to pull people in and create a teachable moment when you can talk about family planning? They can also be used in social marketing. Tests are sometimes available in clinics, and we'll hear more about that later. But when they are, they're often clients are often charged prices for them that far exceed the actual cost of the test. So, and when they're not available, clients are often sent away to purchase one in a pharmacy where the markup is even larger. Pregnancy tests can be very useful for new users of methods like implants. If you've worked much in clinics in the developing world, you're probably familiar with the phenomenon of women coming in. They've become amenorrheic, and they think, rather than being relieved, they think they're actually pregnant, and they come in worried about pregnancy and asking to have the implant removed. And it's often possible to reassure them just by giving them a pregnancy test to show them that they're not. And finally, obviously pregnancy tests are useful not just for family planning purposes. They're widely used, of course, for antenatal care, and research has shown that when they're available freely, it actually decreases the gestational age of new ANC clients. Women are coming in a more timely way when they don't have to worry about buying their own pregnancy test. Let me wrap up by just saying a few words about when a pregnancy test should be used, and perhaps more importantly, when a pregnancy test should not be used, because we think that misuse of pregnancy tests is very common, and the guidance that is currently available about how to use a pregnancy test can be confusing and contradictory. So in the case of my wife 30 years ago, who came in between two normal periods, would a pregnancy test have been indicated and useful? And the answer is no. Pregnancy tests do not work until a woman has missed a period. They're simply not sensitive enough, and lots of people don't realize that, and they use one anyway, or maybe they're using it as sort of a crutch or to cover themselves when they do want to provide a woman a method, because women really do want their family planning. So we do need to improve the guidance and the training about how to use pregnancy tests. To that end, we're working on some new guidance that focuses on telling a provider when they should use a history, when they should use a pregnancy test, when they should use both, and more importantly, when a pregnancy test is not useful. So I will wrap up with that. That's just a bit of background to get the day rolling, and I'm going to carry on to the next speaker, who's Alison Comfort from Apt Associates, who's going to give us a case experience from a project that they've done in one country, Madagascar.
Thank you very much, John. I'm thrilled to be here and to have the opportunity to share our research. I'm Alison Comfort. I'm a health economist at Apt Associates. I've led a number of randomized experiments on different health interventions and was the principal investigator on this study. So I'll be sharing the results of our study looking at the impact of free pregnancy test kits on contraceptive distribution based on a randomized experiment in Madagascar. This was a study conducted through the SHOPS project, which stands for Strengthening Health Outcomes Through the Private Sector, and was funded by USAID. So I'll start with some background. So as we all know, there still remains significant unmet demand for contraceptives, especially in sub-Saharan Africa. And increasingly, contraceptive provision has been shifted to community health workers, or CHWs, to improve access, particularly for women in remote and rural areas. CHWs are trained to provide oral and injectable contraceptives, which are the most popular forms of contraceptives in many countries in Africa. They sell these contraceptives at a small profit. So the WHO, as we've heard, recommends that health workers confirm that a woman is not pregnant before offering her hormonal contraceptives. And so CHWs have been trained to rule out pregnancy using this pregnancy checklist, which was developed as a low-cost tool because pregnancy tests were not available. However, as we just heard from John, there are some challenges with using this checklist. So some women end up being categorized as they could be pregnant when they actually are not and are denied contraceptives. And then as we also heard, CHWs may not trust the woman's responses. And what we found in our own sample of CHWs in Madagascar is that all of them reported having used the checklist, but only 46% reported viewing it as reliable. So you can see there are certain barriers to providing hormonal contraceptives. And so our intervention involved providing these CHWs with pregnancy test kits to distribute for free to women in their communities. There are a number of benefits from using these pregnancy tests. So they're easy to administer. The false positives are highly unlikely. And as we've heard, they've become increasingly affordable, so they're a viable option, especially in low-resource settings. And so the idea is that this intervention, providing CHWs with pregnancy test kits to distribute, could increase contraceptive distribution potentially in two ways. So one, it could improve access. CHWs could use the test as a complement to the checklist and avoid denying women contraceptives. It could also generate interest in family planning. So say a woman wants to know if she's pregnant or not, she approaches a CHW to get a test, and this becomes an opportunity to counsel her in family planning and potentially provide her with contraceptives. So our research question was, does providing CHWs with pregnancy test kits increase the number of new hormonal contraceptive clients per CHW? And the outcome of interest that we looked at was the number of new hormonal contraceptive clients per CHW. So now I'll talk about our study methodology. As I said, we implemented our study in Madagascar, in the 3 eastern regions of Madagascar. And we did it with the CHWs who are working there and supported by the Santenet 2 project, which is a USAID-funded project where the CHWs were trained to sell both injectable and oral contraceptives. We used a randomized experiment as our study design. So of our sample of eligible CHWs, we randomly selected some of them to be in the treatment group, and then we randomly selected some to be in the control group. The CHWs in the treatment group were given these free pregnancy test kits, as well as a training on how to use them, since most of them had never had experience with pregnancy test kits before. And then in the control group, they didn't have access to the pregnancy test kits or get a training on them. And so the benefit of using a randomized experiment is that you can essentially compare the outcome of interest for your treatment and your control group, and that any difference can be attributed to the impact of the intervention. We collected baseline characteristics from our CHWs before the experiment and then follow-up data during a few months later. And this just gives you a sense of the baseline characteristics. So most of the CHWs were women. They have on average a 5th grade level of education. They live at least 2 hours from the nearest health center. So they're really serving women who have limited access to other family planning providers. And then on average, they're selling contraceptives to 39 family planning clients. Now I'll share with you our results and then the policy implications. So we saw that there was a substantial increase in the number of new hormonal contraceptives as a result of having access to these free pregnancy test kits. So there's a 26% increase. I'll just walk you through the graph. On the right-hand side in light green, you're seeing that in the control group, those CHWs had 2.5 new hormonal contraceptive clients per month. And as a comparison, in the treatment group, these CHWs had 3.1 new hormonal contraceptive clients per month. So that difference of 0.7, or almost 1 new additional client per month for the treatment group, represents a 26% increase relative to the number in the control group. So we see a very substantial impact. And we looked at it for both injectables and oral contraceptives and found an increase for both of those. So based on these results, we've shown that this intervention can be a very effective approach to increase distribution of contraceptives in countries like Madagascar. And what this suggests is that pregnancy test kits should be included as a low-cost addition, particularly in these community-based distribution programs. Based on the results of our study, which we shared with the Ministry of Health and USAID in Madagascar, the Ministry of Health decided to scale up the distribution of free pregnancy test kits throughout the country. And then I would just like to share that these studies results have just come out this month in the journal Contraception. So if you'd like to read more detail about the study, it's available here. I'd like to finish with sharing some details about the scale-up of the intervention. So one of the first steps when we presented these results that the Ministry of Health took was to include pregnancy test kits as part of the essential medicines list in Madagascar. And to our knowledge, this is the only country that has added pregnancy test kits to their national essential medicines list. So it makes them easier to procure these, as well as showing their commitment to distributing them in country. They also created a technical working group with key stakeholders to inform the scale-up. So then USAID was responsible for procuring the pregnancy test kits. So far they've procured a total of 700,000. And just to give you a sense, in our sample, we found that CHWs distributed about 7 tests per month. So that gives you a sense of how many they're using per month with their clients. These tests are being distributed by a social marketing organization. In our case, in Madagascar, it's PSI, so bringing them to the distribution points. And then the Mikulu project, which is a 5-year USAID project, is responsible for the scale-up. And so they've been leading the trainings of the CHWs to incorporate these tests in their work. So as of last August, Mikulu trained about 3,000 CHWs. They integrated the training of the pregnancy test kits as part of the refresher course that these CHWs regularly get on family planning. They're trained to use the test as a complement to the checklist. And then the CHWs have also been asked to collect some monitoring data to look at the number of new family planning users and also ANC referrals. So it's another outcome of interest. And this just gives you a sense of some of the preliminary results that the Mikulu project has found. So they found during the month after which these pregnancy test kits were available, there was a total of 6,500 new contraceptive clients. And this is in comparison to about 4,500 on average during the previous months when these tests weren't available. So it's a 45% increase, which is a substantial increase. And these are the preliminary results. But it still shows a substantial increase. There's also anecdotal evidence that the CHWs really like using these tests because it facilitates their work. There are certain challenges that they've found. So some CHWs find it easier to incorporate these tests in their work as compared to others. They haven't had access to other supplies like gloves and sterile cups, so that's been one challenge. And then in terms of waste management, so figuring out what to do with these supplies after they're used. So we're very much looking forward to seeing more finalized results as this scale-up continues, and thrilled to figure out how to inform other countries wishing to implement similar interventions. Thank you.
Thank you so much, Alison. My name is Kate Rademacher, and I'm a technical advisor at FHI 360. And I am going to, oops, sorry. Okay, hold on, we're going to advance to the next slide deck. Okay, great. So again, I'm Kate Rademacher from FHI 360, and I'm very pleased to share results from an assessment that was just recently conducted in Kenya, Malawi, and Mali. We want to express our gratitude to the Reproductive Health Supplies Coalition for funding this work through the Innovation Fund grant, and we're really excited to be sharing these findings today. Just briefly, this assessment was conducted in partnership between FHI 360 and Marie Stopes International. The goal of the assessment was to better understand the availability and affordability of pregnancy tests. We've heard anecdotally that pregnancy tests are very expensive to clients in the field, but up until this point we haven't had any systematic look at that issue. And also as part of this assessment we started to look at questions of quality, just in kind of a light way for now because this is a small grant and a short timeline. But as my colleague Tracey will speak about in a moment, we looked at issues like our pregnancy tests past their expiration date, do they have a CE mark, etc. But I'm going to focus my part of the presentation on questions involving availability and affordability. And I just want to mention that this assessment really aligns with RHSC's 4 strategic pillars, which are ensuring equity, availability, choice, and quality of reproductive health supplies. I also want to acknowledge the project team. Many of the project team members are on the phone, on the line today, and so I'll encourage them to jump in as I'm going through the slides and also in the discussion section at the end to share their thoughts. So just briefly about our methodology. We visited public and private sector facilities as well as pharmacies and drug shops in the 3 countries. And we typically spoke to the manager, the clinical, the facility in charge, or comparable personnel. We purchased or requested samples of the pregnancy tests, and we asked for the least expensive they had available that day, which I'll talk more about in a minute. We used a convenience sample with most of the sites in the capital cities, but some in semi-urban and rural areas surrounding the capitals. And we also conducted interviews with national stakeholders, Ministry of Health personnel, and regulatory experts. So you'll see from this slide that we collected information from 128 facilities across the 3 countries and across the 3 sectors. And just to clarify, for the purposes of this assessment, we defined public sector as facilities or programs run by the government, whereas private sector included facilities by international and national NGOs, faith-based organizations, social marketing groups, and of course privately owned for-profit clinics. So one of the nice surprises from the assessment was that availability didn't seem to be a big problem. Most of the facilities that were included in the assessment reported that they typically have pregnancy tests and on the day that we visited them. That's the blue bar. The red bar is facilities where they typically have pregnancy tests available but not on the day of the survey. So between the 2, you can see that stockouts or lack of availability doesn't seem to be a big concern, at least in the facilities that we visited them. We asked what type of pregnancy test the facilities had available, and by far the most common was the dip strip urine test, which is the inexpensive test that John was just speaking about a few minutes ago. As I mentioned, we were a bit surprised to see the high availability because anecdotally we often hear that women are sent away from clinics when they come and they're not menstruating and are told to purchase a pregnancy test off-site and then return to the family planning clinic. So I also want to share these findings, which kind of provide a slightly different picture. We asked the respondents the question, if there are ever occasional stockouts or if pregnancy tests are never available at your facility, are women ever instructed to go purchase pregnancy tests elsewhere? And so in Mali, only 26% said that women are sometimes sent away, but in Malawi and Kenya, 68% and 61% of women are sometimes sent away to purchase tests off-site. So this suggests that those women may face a barrier if they're told to go away and come back in terms of returning. And it also does paint somewhat of a confusing picture based on the high availability of why women are sent away sometimes. So I think further investigation is needed in this area. Now we want to dive into the data we collected about the price of pregnancy tests. And again, the big issue that we'd heard at the outset of this was that pregnancy tests can be very expensive. And indeed, we asked respondents to give us or sell us the least expensive pregnancy tests they had available. And for each sector, you can see the number of pregnancy tests that were offered for free. So along the private sector, the public sector, and the pharmacy row, the third row in each of those shows the number of free tests. And then the mean and the ranges include the tests that were sold that were not free of charge. So the mean ranged from the lowest of 35 cents in the public sector in Malawi to the high of just over $2 in pharmacies in Mali. Also looking at the full range, the lowest price was 35 cents in several locations, but then up to a high of just under $6 or $5.87 in a private facility in Kenya. And again, remember these are the least expensive tests available, so this is just the low end of the spectrum. As John discussed in his presentation, we know the pregnancy test can be procured for as little as 10 cents and sometimes even less. So these prices really represent a big markup. Even in the public sector, you can see that in Mali and Kenya, women are paying $1.72 and $1.86 US respectively. And these costs may be prohibitive for some women who may be told to return during their menses if they can't pay, leaving them vulnerable for unintended pregnancy in the meantime. And as I think if we reflect on sort of what is the full cost to clients of the contraceptive commodities and services, an important question is what percentage of the cost is really represented by the pregnancy test itself. So regarding availability, one thing we were interested in what type of clients have access to pregnancy tests, meaning whether they're available to family planning clients. We often hear that ANC clients are the ones that receive pregnancy tests. But our data suggests otherwise. We were pleased to see that in the blue line that any client was responsive who has access to pregnancy tests. And in all cases, the percentage of family planning clients who can receive pregnancy tests was higher than ANC clients. So again, this was somewhat of a surprise and was juxtaposed by a quotation from a MOH official in Kenya when asked, are pregnancy tests procured for family planning programs? Specifically, the answer was no. Which programs are they procured for? They go for antenatal care to confirm pregnancy. So in trying to unpack this a little bit, one possibility is that there may be a disconnect between how procurement groups plan for the use of pregnancy tests and what actually happens at the facility level. Another possibility that one of our team members hypothesized is that by the time women go for ANC services, it's pretty clear that they're pregnant and they don't need a pregnancy test, and so again, they're repurposed. So again, but further investigation is warranted. So we also looked at awareness, availability, and use of the pregnancy tests. And you can see that across the board, checklist, the use of the pregnancy checklist, which John and Alison spoke of just a few minutes ago. You can see across the board, and particularly in Mali and Malawi, awareness, use, and availability and use of the pregnancy test was quite low. Awareness was fairly high in Kenya, with 60% of facilities respondents indicating that they are aware of the pregnancy checklist, but still there, just under 40% report typically using it. So I think some of the challenges that John and Alison spoke of were reflected in our findings as well. Here's a quotation from, again, a MOH official in Kenya. To rule out pregnancy, providers typically would find out if the woman has menses or not because the checklist is there, but how many have been trained, how many have been caught up with? Typically it will be a menses history. So when we asked how do facilities rule out pregnancy in non-menstruating women, the vast majority said that they use a urine pregnancy test. And we asked what would typically happen if a woman who is not menstruating. And so again, the urine pregnancy test was the most common answer, with pregnancy checklist having a much lower response in the second column. You can see there. Can you stop me? So again, this perhaps suggests that pregnancy tests are a preferred tool for ruling out pregnancy, and further underscoring the need to make sure that they are affordable for women. So just a few key takeaways regarding availability and affordability before I turn it over to Tracey. So just to reiterate some of these points, it seemed that availability of pregnancy tests was not the main issue, although in Malawi and Kenya more than half of women are sometimes sent away to another site to purchase pregnancy tests. But really the takeaway is that across the 3 countries prices were high. The average price to consumer was 4 to 21 times the procurement price, and the range was 4 to 59 times the procurement price, assuming a procurement price of 10 cents. High markups were observed across public, private sectors and pharmacies. And so I think one of the follow-ups is to further understand where in the supply chain these markups are happening. Is it at the facility level or earlier in the distribution network? And again, just to underscore that availability and use of the pregnancy checklist was low, particularly in Malawi and Mali. So now I'm going to hand it over to Tracey, who is going to speak to us about quality and procurement considerations. Tracey, are you there?
Thank you, Kate. Just moving the slide along. Thank you, Kate. I'm Tracey Brett, and I'm a supply chain consultant with FHI 360. And in my prior life, I was supply chain director with Maury Stokes International for a number of years. So this was really great for me to work with both FHI 360 and ex-MSI colleagues on this assessment, looking at pregnancy tests in these 3 markets. I will be taking a slightly deeper dive into the procurement and quality considerations that we looked at this, within this assessment. As Kate said, this is a sort of a light touch on the procurement and quality. We didn't have that, we didn't go into a lot of detail, but there were some interesting findings. So the methodology to get to some of these findings is that, we had interviews with Ministry of Health and national regulatory personnel in Kenya, Malawi, and Mali. We reviewed a number of pregnancy test samples from the field. With all the interviews, the people who were conducting the interview either took a photo of a pregnancy test, or they bought it if they were able to, or they jotted down the details. We had discussions with family planning, global procurers, and a number of others who are interested in pregnancy tests within the supply chain and supply chain stakeholders, and reviewed available information on international pregnancy tests and quality standards. Which leads me on to my next slide, which is just looking at the 2 well-known quality standards, or better-known quality standards that are applied to pregnancy tests, which are a medical device. Just to note, this is not a comparison between the CE marking, which is a European quality standard, and US FDA 510K. It's just given an overview of what we know. So on the left, CE marking, which is the quality standard for the European Economic Community. Pregnancy tests are classified as in vitro diagnostic medical devices. The CE marking, so there's actually a mark on the pregnancy test, applies to a specific product or product family from the same manufacturer. But that does mean even if the manufacturer can provide or show previous compliance, this does not mean all products manufactured are CE compliant, which can sometimes be confusing. The importer is responsible for ensuring compliance and is often considered the manufacturer. And that's in brackets or inverted commas, because if the importer is marketing under its own trademark or own label. So that often happens with pregnancy tests. So that is why often you'll see the manufacturer will list an agency or organization in Paris. They're not the actual true manufacturer, but they're considered the manufacturer in the CE marking. And a notified body, who's an independent organization that has been accredited to assess whether a product meets certain standards, should verify the design of the pregnancy test. And then in turn, their compliance number should appear after the CE mark symbol on the product. And on the right, we have just some notes on US FDA 510 clearance. This is the US quality standard. And pregnancy tests are US FDA regulated as a Class 2 device, so they consider them as a moderate risk and require 510 clearance prior to marketing. So similar to CE marking in that it applies to a specific product or product family. FDA staff do review a number of performance factors during the 510K review, including precision, cut-off performance, accuracy, and stability. So that refers to shelf life. They also look at inserts, the labeling, which is very important, and also interesting, they do conduct pre- and post-market reviews of pregnancy test devices. And a recent report shows that actually there are very few false positives or false negatives reported. Unlike the CE mark that is displayed, there is no symbol displayed on the product for 510K. So looking at the Innovation Fund project did look at the quality of pregnancy tests through the samples. And it's quite interesting what we found. Quite positive results looking at products that weren't expired, although having any expired product in a facility or available to procure by a client is never good. Written instructions in the correct language, you will see that was also fairly good, with the exception of Mali, where a lot of the instructions were in English, so not in French. The illustrated instructions, this was really good. Great to see that, because even if the pregnancy test instructions are available in English for Malawi and Kenya and other markets, often women can't read, or it's not their first language, and therefore the illustrated instructions are important. And then lastly, the CE mark, there's a CE mark peer, which is sort of the de facto global standard. And this was where our concerns were raised in a number of these, and particularly in Malawi and also even in Kenya. It's very low, quite low number of pregnancy tests actually displayed the CE mark. My next slide is just samples from the field, and I picked up, I've displayed two samples. The one on the left was found in a public sector facility. It had no international quality marks. You can see it doesn't reference a CE mark anywhere, and therefore we can assume it is of uncertain quality. We're not saying it is, but there's nothing no evidence to show that there has been any international quality work done on this test, on this pregnancy test. The one on the right displays the CE mark. I think actually the arrow might be exactly at the top of the arrow where the CE mark is. And it also gives the notifying body number, which does give a greater layer of confidence that the product has gone through the correct quality assurance mechanism for CE marking. This leads us to some of the procurement, quality and procurement challenges that we found, having looked at the project, the samples that we picked up, and also having discussions with a number of stakeholders, that there are concerns about fake or suspect CE mark products entering the market. And this came out quite strongly in some of the discussions we've had with people, and also the confusion around the CE mark. A number of the samples collected through the Innovation Fund project didn't have any evidence of international quality standards, as we've seen in the earlier slide. There was a limited regulatory approval or oversight around the quality of tests at national level. Though a number of people we spoke to did indicate that this was something on the radar, and often it was a case of resource. Limited information and visibility for procurers on the supply side. So, procurement and having information around procurement, and especially if it's a new product you're procuring, is really close to my heart, because I've done this for a number of years. And it's sometimes difficult if you're having to vet a number of potential suppliers, and and there are a lot of manufacturers of pregnancy tests. So there's a lot of manufacturers, and it's not a lot of information on the suppliers. And it's quite difficult to vet this big pool of manufacturers, especially if you have limited resources. Not a lot of shared information, or very limited shared information on suppliers' prior performance. The methods to verify quality, including pre or post shipment testing, is not really available internationally, and often this has to be sort of figured out agency by agency. and a lack of standardized specifications. So once again, agencies having to do this themselves and not a lot of harmonization or shared information. And this coupled with the fact that the international procurement of pregnancy tests is split across a number of buyers. So, and within these buyers, the product is relatively low volume and low value. And this will often translate into no dedicated resourcing for quality assurance, so limited sharing of information and pooling of resources. So it really hasn't got that importance that perhaps it should do. A quote that we got from an interview with the Kenya Medical Laboratory Technicians and Technologists Board, it's quite difficult to say that, from an official in Kenya was, we cannot give you the data of how many inaccurate results. There's quite a bit that goes on. This is really an area of concern for us. So highlighting, quality concern from that high level. And KML-TTB needs to be supported so we can also undertake post-marketing surveillance. We need to be very vigilant. We just want to touch a little bit about the source of supply of pregnancy tests. Where in the questions is asked, do you know where your source of supply comes from? And unfortunately, some of the questions weren't answered, in full, but where we did, we were able to do some analysis. And it is interesting that in Mali, a lot of it's through local NGOs, which is great to see, through social marketing and social franchising. So local pharmacy chains, wholesalers, the private sector, also through the private sector, also through local NGOs and local pharmacy chains. But quite dispersed. Malawi seems to have a much clearer strategy around procurement in the public sector through the MOH. Private sector also through social marketing and social franchising, which is touching on John's point earlier about the role that social marketers and those social franchising networks can play. And then pharmacy chains and wholesalers. And Kenya is quite mixed. But I think what I wanted to say, what I want to use this to illustrate, is that it's quite a mixed bag of where the procurement is coming from, and it's not much consolidation. So even at ministry level or public sector level, sometimes from MOH, sometimes from local wholesalers, sometimes from NGOs. So not a lot of consolidation or centralization, which could impact quality, access, and pricing. We heard a little bit earlier about pregnancy tests being added to the essential medicines list in Madagascar. We were able to get some findings from the International Consortium for Emergency Contraception's Innovation Fund project, who also, were looking at pregnancy test availability. So in all three countries we looked at, the pregnancy tests are not on the essential medicines list. And the only countries in Sub-Saharan Africa, Asia, and Latin America that do have pregnancy tests on the essential medicines list are Cape Verde, Cote d'Ivoire, DRC, Madagascar, Namibia, Rwanda, and then you've got 3 in Latin America and only Papua New Guinea. So it's a very, very small list. And I think, we wanted to just raise this as a point of a question for discussion, which, I'm sure people would want to input into when we open it up to discussion, is should pregnancy tests be included in the WHO and or a national essential medicine list? And would their inclusion lead to an increased demand for pregnancy tests for family planning and maternal health programs? And then in turn, increase focus on quality and supply chain issues. So that is just a question that we were pondering. And then our key takeaways on quality and procurement, and also ones that we hope will be discussed further, is that our assessment indicates that there is a lack of knowledge and confusion amongst consumers, providers, importers, distributors, even pharmacists, and even in some cases regulatory personnel on the internationally recognized quality standards for pregnancy tests. And we saw this quite a bit of evidence in the questions, the questionnaires. There was confusion between the NAFDAC, which is the registration number for Nigeria, versus that and an ISO number, international standard, quality standard number. and also confusion between the different ISO numbers, such as 9001, which looks at overall quality, and 13485, which looks at device quality. But it's just, the people's, knowledge. There could be, further information and shared information on this to increase knowledge. A lack of publicly available protocol for pre- and post-shipment testing of batches. A lack of strategy, focus, and harmonization around pregnancy test procurement. And then, once again, we have another question that we're putting up for discussion, which is, would a more coordinated approach amongst donors and implementing agencies help address challenges around pricing, quality, and availability? Thank you.
Hi. Can everybody hear me? This is Amy Lynn from USAID Center for Accelerating Innovation and Impact. I'm just going to introduce myself again because I think this microphone is coming in and out. Okay. Great. So thank you, Tracey, for that presentation, and thanks to all of the previous speakers about laying out so much of the helpful context as we understand more about the pregnancy test market. As some of you may remember from a similar webinar about a year ago, USAID Center for Accelerating Innovation and Impact presented a framework that we have outlined in the Market Shaping Primer. What we've actually done is, in speaking with these different groups and hearing about the evidence coming out of the RHC Innovation Fund project that we just heard about, as well as the data coming out of Madagascar from the SHAPS project, we were really intrigued in understanding more about what the market of pregnancy tests could look like, and if there might be an opportunity here to shape that market for a greater impact and to remove this potential service delivery barrier. So, as you may remember, the framework that we had outlined in that previous launch of the primer is described on this slide here, which shows the 5 blue columns, starting with observing what's happening in the market, observing any possible shortcomings, moving to then diagnose the root causes behind those shortcomings, assessing what could be done in terms of market shaping options, so thinking about what has been done in the past across health sectors and what might be applicable here, and then looking how to customize such an intervention and implement it, and then measure the results. And so we'll be focusing on just the first couple steps here to draw on the data that we've just heard about around the market and the possible root causes. So if we take that first step of observing market shortcomings, we can look at it in different ways that we call the 5 A's. So looking at the affordability of the product, how available is it, both globally in terms of is there enough manufactured in the world, but also at the service delivery point when it's needed. Thinking about assured quality, which Tracey just spoke about, and then thinking about the appropriate design of the product and any potential awareness among how to use it by both users and providers. And if we look at it, looks like the animation on this slide might be a little bit tricky, so hopefully those who are on the line can actually see more of the notes. But what we have done is, and we can send out a detailed version after, taken each of these 5 factors and given it just a high overview sense of the status. So affordability and availability seems weak, or at least on availability very conflicted. Assured quality also very mixed in that there were high quality products available and there are markers to indicate that quality, but there's a lot of confusion about how to find those markers, how to make sure that they're genuine and not counterfeit, and also recognizing that there are sub-quality products available in these markets. On the affordability side, I think Kate touched upon a lot of these pieces in terms of looking at the very high markups of 3 to 21 times the actual procurement cost, and that's just for the least expensive option available. So you really need to look at this very carefully, because even in the public sector, we're seeing that clients are sent away to purchase them, or they need to purchase them on site. They're not always available for free. And then in terms of availability, just as Kate had talked about, some of these inconsistencies that we're seeing in terms of where they might be available in care or family planning, hopefully both. But then also the fact that we've seen a high proportion, almost half, sometimes being sent away to purchase tests off-site, trying to understand that better. In terms of appropriate design and awareness, we actually saw that the data that we've heard and that we've seen collecting these various sources indicates that these areas are quite strong. So the test is easy to use, it's cheap, it's straightforward. Providers
seem to be able to be well trained on them and use them. And in terms of awareness, there seems to be a real interest in using them, both from the providers and the end users. So those seem to be, those shortcomings didn't seem to be there as much in those two market factors. And then if we really dig into root causes, and that's the next slide here, we can see that there might be root causes around the transaction costs, the availability of market information, and the risks that are in the marketplace that could be addressed. And so this is a very initial analysis, and so we look forward to continuing to get input and further discussion on how to understand these better. But for the transaction costs, so for a supplier to meet an order, right now the transaction costs can be quite high because the demand is fragmented and it's splintered by different groups ordering in relatively small order sizes. So we heard that NGOs might buy them, national governments, it could be donors, it could be for-profit actors, but they're not doing it in a coordinated way, and so it's much a higher transaction cost for the supplier to respond to those orders. And the orders that would be dedicated for family planning versus antenatal care, even in the same country, are also not necessarily coordinated, and so there's an opportunity there possibly to consolidate and make that more efficient. In terms of market information, a lot of the data that we have has just come out very recently. We heard that the data on Madagascar was just published this year in Contraception. So making that information more available and sharing that with potential procurers who may also view pregnancy tests as still too expensive, even though there have been relatively recent price drops. And then better understanding the demand on the provider side and the end user side, and understanding how that can work in conjunction with the checklist, as we've discussed earlier. And then finally, thinking about risk imbalances, so that the current demand, as I mentioned, which is relatively uncoordinated, and as Tracey very eloquently put it, is for a product that is low volume and low value for suppliers, is not very attractive for these manufacturers. So is there a way to offset that risk and make it more attractive for those commercial manufacturers to participate in this market for low and medium income countries? What I've got on this next slide here is also taken from the primer, and it lists different market shaping options that have been used in the past, not necessarily limited to the family planning field. So these are drawn from the HIV field, malaria, vaccines, maternal and child health, and family planning. And what I've listed here is just a menu where we could start from. So as we think about these market shortcomings and the root causes that may be behind them, what are options that we could do? Can we look at product bundling? Can we look at making pricing more transparent? Can we think about demand forecasting and many others that are listed here as possibilities? And so as a recap, because I know we want to move into hearing more from the group that's participating on this webinar, I've summarized here some of the key points around the opportunities around market shaping for pregnancy tests. We really see a potential to generate significant health impact. I think John's data and Alison's data really speaks to the service barrier that the lack of pregnancy tests can pose. When we hear that nearly half of new clients who are not menstruating nearly half of new clients aren't menstruating, and an estimated 17% of these are denied, and that denial rate can drop by as much as 4 times and lead to increased hormonal contraceptive access through community health workers in Madagascar by over 20%. And so these are sizable proportions that we really want to take a closer look at. As mentioned, the high price to end users and uncertain availability, and I think we could even think more about the quality pieces in the market shortcomings as well, moving to the fractured procurement and low awareness of the potential health impacts as possible root causes, and then suggesting some ideas to start the brainstorming around what could be done in terms of addressing these with demand forecasts, pooling the procurement, bundling, and conducting additional research to get more data on this. So with that, I'll wrap up on the presentation side and then look forward to your questions and comments.
Thank you, everyone. This is Kate Rademacher, and I think now we're going to move into an open discussion phase. We have about 25 minutes. And so I think what we're going to do, I'm looking at Anita and Sophia, we're going to unmute all the lines and try it. So we're going to strongly
The conference has been unmuted.
We're going to please ask everyone to mute their line if they're not speaking so that we don't get feedback. But really open the discussion. And if it doesn't work, we can mute the line again and just have folks type their comments and questions in the sidebar. But let's try this for now. So again, I just want to thank all the speakers and RHSC for creating this platform. And I think what we can now hope to hear from is questions about any of the content that was presented, the research from Zambia, Madagascar, the Innovation Fund project, and also get your feedback about Amy's presentation about market shaping opportunities or other thoughts for expanding access to affordable, high-quality pregnancy tests. So please go ahead and jump in if you have a thought to share.
We have one in the room.
Oh.
I just want to congratulate all of the presenters for the informative presentations that you made this morning. I had a Sure. Hi, this is Carmen Tull from the MCH division at USAID. Just want to thank all the presenters for their presentations this morning, and I had a quick question for Alison on the data coming out of Madagascar. Do you have initial data? You presented initial data on new family planning users, and I was wondering if you had initial data on ANC referrals from Madagascar.
No, so unfortunately from our pilot study we didn't collect that, but I know it's a big interest for the McCoo project, so they'll be looking at that. I think like there's two important benefits from these pregnancy test kits in terms of family planning use and earlier ANC referral. And they found mixed results on ANC so far, but it's not their final results. So, but they're definitely tracking that.
Hi, and this is John Stanback, and let me just briefly add that there is some interesting evidence from South Africa showing that when clinics provided pregnancy testing freely to the clients instead of forcing them to go out, this is antenatal clinics clients, forcing them to go out and buy their own tests, that on average they started their antenatal care about a month earlier.
So, John, that was sort of my follow-up question was related to your statement about research has shown that when the pregnancy tests are available, is that that there is an increase in referral? Is that the research you were referring to, or are there others?
Yeah, that's what I was talking about. It wasn't exactly referrals. It's about the availability of pregnancy testing during antenatal care and also abortion care. When abortion is legal in South Africa, and when women but they make a woman get a pregnancy test prior to the procedure. When those tests are available freely, the woman gets more timely services and on average was waiting a couple of weeks longer for services when she had to go out and buy her own pregnancy test.
Okay. This is Donna Vivio from USAID, MCH Division. So just to follow up, just to be clear, so it's not really related to those who presented for family planning and received, for some reason did the pregnancy test and then were referred to ANC. This is really about those who were able to get the the pregnancy test during ANC or abortion service.
That's correct. If a woman is at a family planning clinic and has a test and it's positive, then typically she would be referred to antenatal care.
Is there any evidence that happens and how much earlier, et cetera?
We don't have any data about it, but typically it would mean that the woman did not know she was pregnant and finds out, and so didn't have to wait until she missed a period or something.
I just say that because it would be great to know what the potential, the added value would be in terms of early pregnancy care. It would be really great.
Right. On the other hand, the jury is not. Or early termination, where that's available. Yeah. Good point. On the other hand, the jury is out about how much benefit women get from earlier antenatal care. The earlier visits may not be as useful as later visits, and it depends on the services available.
Trish, to you, I think we have, just to clarify, we have some people on the phone and some people in the room. So I think, Trish, we can take your comment next, and then we'll go to folks who are online.
Okay, great. Thank you. This is Trish McDonald from USAID Family Planning Office and Service Delivery Improvement. And I have a couple questions on the research that was conducted with respect to the training and the actual use of the test by those who had gone through the training. In terms of how many of those tests were used for women who were between menstrual periods as opposed to having missed a menstrual period or having had a late return for a contraceptive that they were already using, one question. My other question for Madagascar specifically is that you mentioned that about 7 tests were used per community health worker per month and that it resulted in about 2.5 new users per month. Can you explain what happened to the other 4.5 or 5.5 users? Were they pregnant? Were they between delayed contraceptive use? Those kinds of things. Because kind of a 65% then of the test didn't result in contraceptive use. So can you describe a little bit about who those clients were and what their situations were?
So I think all those are great questions. I think one of the limitations from our study is that we really relied on monitoring data, and so ideally, if through a survey we could have gotten better information on who was getting the test, what those client characteristics were. So our data is pretty high level, and we can't dig down deep enough for that. So we knew that they gave out 7 tests per month on average. We also know that they use the checklist on average 2.5 times per month. We don't know, so that tells us that they might have used the test in complement to the checklist with some clients. Maybe other clients were ones who it's that potentially second pathway. They wanted to know if they're pregnant, and they weren't necessarily interested in family planning use, but finding out their pregnancy status. So that could be the other use of the test. And so that would explain maybe why they didn't become contraceptive users if they ended up being pregnant. So I think it's a limitation of our data that we have these high-level results and we can't dig down on who exactly the test was used with, what their characteristics were. And so I think that's why we have this black box on why did it increase family planning distribution, and is it through that first pathway in terms of complementing the use of the checklist or just generating more interest in family planning? And I think that our second hypothesis, this is a new commodity in these areas, and you think this new product that can give you a good sense, a more accurate sense of if a woman is pregnant or not, you'd think there is a lot of interest in it from the demand side in terms of clients not having ever had access to these tests before. And I actually at baseline, we thought there'd be more distribution per month just because this is a new commodity. But it really, 7 to me seemed low. I was expecting them to distribute more. They were given 50 to start off with. So I think further research on that would be interesting and important.
And this is John Stanback. I'll add a couple of things about the research in Zambia. In Zambia, these were trained nurse midwives, and so we did not give them extra training on how to use the pregnancy test. In retrospect, maybe we should have, because maybe they were not using them correctly. On the other hand, they didn't use that many. They only, in 3 months of use in 5 clinics, they only used about 100 tests. So the total cost for the supplies for this research in Zambia was about $10 for 3 months worth. So they weren't wasting them or anything. Tricia, you asked about how the use of the test broke down between clients who were between periods versus in the postpartum period. We tried to collect that data. In the end, they did not do a good job for us categorizing how they used the test, and so we really didn't get good data about that. Well, we think they used the checklist. We didn't ask them to report on whether they were using the checklist.
Great.
Hello?
Hi.
Hi.
Hi. Can I ask a question?
Yes, please. Go ahead.
Oh, hi. This is Martha Brady from the Population Council. Just thank you all presenters. That was great. And those, John Stanback and Marcus, you'll remember, I think we were in the same age cohort, probably 25 years ago. I worked at the Population Council on our pioneer of what was then Norplant. And so the whole idea of, and at the time, 25 years ago, I said, we need to be able to actually have pregnancy test kits for women so they can find out when they're pregnant and not. So it's music to my ears that this is finally happening. So hats off to you all for doing this. There's many questions I have about all this work. A couple things strike me. Can you hear me?
Yep, we can hear you.
Okay, sorry, because things are going off and on. A couple things strike me that I think would be important. Hello? Go ahead. I'm getting a lot of feedback. Wow.
We're getting
okay.
feedback from the line.
There's a huge amount of feedback. Was that Anita?
No. Go ahead, Martha. And just a reminder to everyone to please mute your line if you're not speaking.
Okay. Several questions, and John and FHI folks, I'll ask you guys about methodologies later, et cetera. But a couple of things really strike me. And we've learned this for 25 years in different areas of contraception and family planning. But one thing that I think came up somewhere was that, the cost to women in all cases was much higher than actually in the program. So if a woman wanted to go off and buy a test kit herself, it costs whatever, significantly higher, right? And this speaks to, I think, because you see this with emergency contraception, you see this with abortion technology, you see this when these are products that are really important for women, actually. And it's about their vulnerability, and prices go up dramatically because they know women are vulnerable and really need this. So I think that's really important thing that I'd like to get to the bottom of. The issue of procurement. This happens forever. We have condoms that get procured not for family planning, but you can procure them for HIV. In this case, I think one of the comments was they would procure the pregnancy test kits for ANC, but not for FP. And I think that came up also in Amy, Lynn, your comments at the end. So this is a problematique that we've seen in this field for a really long time, and it speaks to, I think, the kind of siloing of women's reproductive health, frankly. And so, aside from just like I'd really like to see what really can we actually do to change that. It happens all the time. This is the pregnancy test kit. It happens with condoms. It happens with. So, I'm hoping that we can come to some real movement on that, because I think that's a problem. The other question at the end was, I do think it would be useful to know more data about. I actually would like to know. I think, John, you mentioned only like 1%, if I recall, of women are actually test positive for pregnancy at the time of the, when they're at the time of the family planning consultation or something. I can't remember what the number was. But it was low, right?
That's correct. And we've looked at that.
Right. One of the things I think is really important, and I'll speak because I'm actually from the client's perspective, from the use of women, I think it's really important that we are sure what she wants to make of that information, right? Because we learned 30 years ago in Planned Parenthood clinics in the U.S., when they introduced the pregnancy test kits, it was like, oh, great, a sigh of relief. Women got to know most of them weren't pregnant, and that was like, oh, good, right? So, but we want to make sure that for those women who actually then are actually positive and don't want to be, that there is an opportunity for not everyone and their brother needing to know if they want to go for termination. I think that's the piece that we didn't talk about at all here, but I think it's kind of important in all this. And then there's other questions around quality of supply, which I think Tracey touched on, which I think there are many, many issues there. So I have lots of other questions, but I guess I'll get in touch with, I don't know what the mechanism is, Sophie, but should we just get in touch with the researchers directly?
Yes, that would be great. And thank you, Martha. And I'd be more than happy to talk to you offline anytime.
Yeah, because it's interesting. So lots to say.
I think we have a flag that Mark Hathaway from Topeka is going to have a question. But just also, as we look at the time, I just want to reiterate what Anita said, which is that pregnancy tests are one of the priority commodities in the new and underutilized reproductive health technologies caucus of the RHSC. And so we'll have opportunities to continue discussing this topic through that forum, and there's a meeting next week, I think, right? And so maybe we can have some follow-up there, too. But Mark, did you want to share a thought or a question?
Yes, thanks very much.
And is there time for another question afterwards? This is Denise from USAID. If there's time for another question afterwards, that would be great.
Sure, absolutely.
Yes, thanks very much. This is Mark Hathaway. I'm thrilled with this information. It's great work. Obviously, cost is huge, and the lowest common client or women, I think, is where a lot of our attention and focus should be. Those in the most rural areas that are having trouble or don't ever get to a family planning setup or a community health worker to begin with. But once they do, then the key is to help them get on a good, effective method and not turn them away. So this is a step towards that. So I'm not really sure exactly who to direct the question to, but perhaps Alison. You know, in looking at those community health workers who felt as though they were unable to trust women, or they felt that the test wasn't as reliable, did the conversation ever shift to what in the event would happen if they were to go ahead and provide a contraceptive method to those women, and what the consequences would be, if any? Did they understand that at all, do you think? Was that ever asked?
So we collected some baseline data from the CHWs to get a sense of what their beliefs about the checklist were, and I think what our findings showed was that, so they'd been trained on using the checklist, but then a large proportion had reported we were actually instructed not to provide hormonal contraceptives to non-menstruating women. So, I mean, this highlights that there was definitely a problem with the initial training on using this checklist, because they'd clearly been trained on it, but they were still reporting we've been instructed to not provide these contraceptives despite having access to it. And then in addition, they're reporting not seeing it as very reliable. So I think it's two components. It's that side of maybe not trusting the client's response, getting these false positive results, but also just some problem in the initial training. So I think as follow-up, it's important to revisit the training on the checklist and trying to do away with this being wedded to this requirement. And so I think that was interesting to find at baseline.
Great to hear it, because I think you're right in that, you know, the intervention obviously is multifaceted in trying to get women on good contraceptive methods, and the pregnancy test is one modality, but it's also lots and lots of work needed to help clinicians or community health workers understand about the checklist, or the non-really negative consequences, or the, you know, any birth control method is much safer than any pregnancy. So helping community health workers understand that, as well as lots and lots of clinicians, is important.
That's a great point about family planning is always more safer than a pregnancy. I'll add that early on, when we were first doing research on the pregnancy checklist, we did talk to providers a lot about this, and often it comes down to the trust between the provider and the client, and providers told us that women know they're pregnant and they're coming, and they try to use contraceptives, even hormonal contraceptives, to procure an abortion, and even they don't know that does not work as an abortifacient. So providers have told us in the past they don't necessarily trust what the client says to them and how the client responds to the questions that are asked during this medical history.
Yep.
So we have limited time, but I think Victoria Graham, who's here in the room, and then I know there was another colleague from USAID on the line who asked to make remarks. So Victoria, maybe you first, and then our colleague on the phone.
Yeah, this is Victoria Graham from the Office of Population and the Service Delivery Improvement Division. And my question is about the Madagascar study. Yeah, my question is about the Madagascar study. And I think we all agree that any reproductive health or family planning products that we can make available to women is very important. But I think it's a whole other issue on whether or not pregnancy test kits need to be used by every community health worker to rule out pregnancy before they, can offer them an injectable contraceptive or another method. And I'm just wondering, in the Madagascar study, was there ever any discussion about adding an arm where you took another cohort of maybe 260 community health workers, retrained them with the checklist, and just to see what some of the results might be with that? Because I think one of the things we really don't know much about is how the checklist is being used, whether or not it's being used effectively, whether or not community health workers are being retrained, and really whether or not, how many women are really turned away because of it. And we really don't have that information yet. So it would be helpful to hear any thoughts.
No, I think that's a very good point. And I think we initially went into this really wanting to see what's the impact of making free pregnancy test kits available. And we didn't want to, our initial approach was not to go test the checklist and look at its effectiveness, and just really focus on the pregnancy test kits and treatment versus control. But I think in the process of doing this research and getting that baseline data on what their beliefs of the checklist were, it's really highlighting that in itself has been a failure in terms of training these community health workers to use it correctly. And so I think it would be good as follow-up research. It's just not what we'd gone into it initially wanting to investigate. And I think because there's such limited research, rigorous research, looking at the impact of making these test kits available. And so John had looked at it at the health center, and we wanted to look at it with CHWs. But I think this is a good next step, and it's highlighting the synergies between the test kits and the checklist, and refocusing on that training also for the checklist.
It's a great suggestion, Victoria, to use like a factorial design where you give them one, the other, or both, or neither, and really tease out the relationships.
So I'm sorry. I think it was Denise from USAID who was trying to jump in with a comment.
Right.
Online?
I have just a quick question. Yes, I'm on the phone.
Okay, go ahead.
Yeah, just sure, real quick. Denise Harrison from USAID, Office of Population and Reproductive Health. My question is for Kate, but I should say I really enjoyed the presentation. It's very interesting. Kate, if you could say a little bit more on the methodology for your pricing, because you said there's a huge difference between the different prices. How many different products were you looking at the low range, and are you looking at them in different channels and comparing them, or you're saying the price for the relatively same product is very different in the same channel? Thank you.
Thanks for that question. So to clarify, at each facility, and again we visited 128 facilities, private sector, public sector, and pharmacies and drug shops, we just purchased or were given one sample per facility, and that was the least expensive. We asked them to sell us or give us the least expensive that they had that day. So some of them were free. If we return, I guess we can maybe return to that slide. And so that the means that you're seeing are the averages of the least expensive across multiple sites. I hope that clarifies.
Okay, thanks. I'd love to talk offline more about your methodology. Thank you.
Okay, great. So I think we're right at, go ahead. We're right at 10:30.
Sure, I just wanted to jump in. This is Kate Cho from MSH, and I was hoping that my colleague from Madagascar would be listening in and then jumping in to answer some of the questions. Alison, I think you might have been working with Onisu about some of the work that you're doing, but we at MSH are able to help explore some of the research questions that people have been mentioning, because we are scaling up the use of these tests through our network of about 2,400 community health volunteers. And if there's any way we can help look at some of, explore further maybe with qualitative research or looking at some of the CHVs who weren't trained on the pregnancy tests, we're happy to do so. So I don't know how I can reach out. Maybe I'll reach out to Alison, and then she can link me up and my colleagues with the various folks. But that would be something that we're willing to do.
Great. So we are at our time. So I think what we're going to do is, it seems like there's several more questions and comments. And so we'll leave the webinar line open for another 10 minutes or so if people want to continue the discussion. And for those of who need or want to drop off, we thank you so much for your participation. And this session has been audio recorded, and the slides and recording will be posted online. So we encourage you to share with your colleagues and to get in touch with any of us one-on-one if you have questions, and also to participate in the NERDS Caucus meeting next week for further discussion if desired. So thanks again to all the presenters and to RHSC, to the platform, and to everyone who chimed in with thoughts and questions. But so notwithstanding the beeps of folks leaving, if there are additional comments or questions. I think, Trish, did you want to jump in?
Thank you. I guess my question is really from a programmatic perspective, and looking at particularly the Madagascar experience of going from a study that seems to be somewhat of a proof of concept, but without really having full information around whether the pregnancy checklist would really be used if there was better training of health workers around that, or understanding which clients are being offered the test, which ones it's useful for, et cetera, is it being used correctly or not, and then jumping to full scale. And I'm kind of wondering about that whole process in between and what the factors were leading to that, and whether you really think that, from the research that was done, that full scale is really a good programmatic decision at this point in time.
And also, can I jump in on that? I was pleased. It seems like the scale-up efforts themselves are being pretty well monitored, which I think was really exciting for me to see, because often that isn't the case. So maybe you could confirm if that's the case.
So I'll answer that question first. So the Mikulu project, and so I've been talking with the counterparts of the Mikulu project, and basically their project started when our study, when I presented our results, and they kind of just took it forward from there, and were in charge of the scale up and have been very excited about it, and have been doing a good job in terms of getting this monitoring data. And so that's why this data is very recent, and they're going to be tracking it for a year and a half. And they're actually presenting at the Family Planning Conference in Indonesia in 2 weeks, I think. So they've definitely taking it to scale and really trying to monitor it. And we didn't look at ANC referrals. They're also adding that to some of the outcomes they're looking at. So this is very exciting results that could come out of this. I think your question, Trish, about going from our pilot study to scale. So I think while it's true that we're lacking some of that information about who the clients were that received these tests, nonetheless, we're still seeing an important impact. We don't understand maybe the underlying mechanism, so I think that really speaks to needing more research on it and understanding, is it generating more family planning interest, or is it just complementing the use of the checklist? Like, what's going on in the black box? So I definitely think there's room for that. But I think as researchers, we sometimes have few examples of where research has impact and is taken to scale, and this was really the Ministry of Health taking ownership of this. And I think it was somewhat contextual in terms of when we presented our study, the relations between Madagascar and the U.S. government were renewed and more funding had come in after the crisis. And so this was their effort to really show we want to do something good. This has been a great example. And so they did all these really proactive steps, and surprised even USAID at that presentation that they'd already included the test kits in the list of essential medicines. So I agree that there's still a lot of unanswered questions and a lot of room for more research. But given that we're seeing such a strong impact, this was rigorously conducted in terms of being able to draw causal inference. I mean, for me, it's very exciting as a researcher to see it scaled up like this. But there are questions: is there going to be the same impact in other parts of Madagascar? They may differ at different times of years. People have different time availability. So will the CHWs be as active or less active? So I think even with the scale-up, it's really important to see what is the impact and to research that.
So a related programmatic level question is this whole issue about availability of the product and stockouts. And once it's introduced and providers become dependent on it, is there any plan to look at taking the product away and finding out what happens then? Do they revert back to denying women, or do they use the checklist more because that's part of the training? I guess, the whole issue of kind of dependency related to stockouts, things like that, is certainly another programmatic question, and especially if it's not, being procured widely, those kinds of things. So I'm just kind of trying to think of some of those programmatic scenarios and the what ifs. I didn't know if you've had discussions around that in your discussions with the governments and providers and things like that, or whether you're planning to do any research in this area.
I mean, I'm looking at the group. I think we share that concern. We don't want to have a situation where there's an a reliance and a dependency on a commodity and then exacerbate the problem when there are stockouts. And I think that is why we want our clear message to be the takeaway from this and other discussions to be that we're, I think it's clear to reemphasize that we're not the checklist, the pregnancy test replacing the checklist, that we want both tools to be, promoted in tandem. And I know that's not exactly what you're saying, but that there is confusion that we're saying pregnancy test instead of the checklist, which of course is not the case.
But the good news was that the tests are fairly well available, and it's according to our research, although they shouldn't be charging women for this little test more than they're charging for the method, which they usually get for free. And I would say that if you had another kind of health service where 10 or 20% of the women needed an extra action or diagnostic tool or something like that, like TB, I don't think any donor would deny this medically necessary adjunct to the service when it was needed. And in family planning, 10 or 20% of the time the woman needs a pregnancy test if she shows up and pregnancy can't be ruled out. So we should make sure that women can get this, and instead of sending women away and putting them at risk of getting unwanted pregnancy.
So the other question I have then is related to the training around the use of the checklist, and whether part of that also includes the risk of pregnancy versus the risk of family planning in the event that somebody may be pregnant and use of a hormonal contraceptive. And this, essentially it's still safe to give the contraceptive, and I don't really know if that message is coming out clearly as part of those trainings around the checklist. It's
right. We probably talk about abortion more than we talk about that. But no, it's not coming out clearly, and partly because it's still considered a best practice by WHO and everyone else to exclude pregnancy before you provide a method. But there is no good data showing any risk to women if they start a hormonal method while they're pregnant. Of course, with an implant, you would have to go through the trouble of removing it.
Okay, so I think everyone has been so great about hanging in. Is there one or two more comments on the phone before we wrap up?
Yeah, I have a comment. My name is Dr. Solomon from Nairobi, FHI 360. Yeah, I love all this conversation. I've just been quiet, trying to absorb. But I just thought that this conversation about checklists and the pregnancy test, to me, it will end up making us come up with a guideline, sort of an algorithm that will guide a fully trained service provider to know how best to use the checklist, and then when next to use the pregnancy test. And I think that will be able to kind of offer the services that will be there to rule out pregnancy. The other thing which I wanted to indicate is that with all this availability of pregnancy tests has been shown, the issue of quality has come in quite prominently. And to me, as we programmatically, as we kind of effect this intervention, we can't avoid strengthening or calling upon the regulatory authorities to make sure that really quality products enter the market, and even quality products appear and are used in the service delivery point. So that's where my comment would be. Thank you.
Thank you very much, Dr. Solomon, and let me further introduce Dr. Solomon, who is the former Director of Family Planning in the Ministry of Health in Kenya, and currently is a Senior Technical Advisor at FHI 360. I mentioned briefly during my short presentation that we are trying to work on new guidance that would help a provider know when to use a pregnancy test and when not to. And we tried to simplify that by dividing women up into the possible categories. So, as Trish mentioned, women who are between menses versus women who are in the postpartum period and have amenorrhea, and also dividing it up between whether they're using a hormonal method or an IUD. And so I showed a fairly complicated slide that's up now, but depending on the woman's situation, the guidance for her is only in one of those cells. So I think it would be a great idea if we can get this new guidance shared and vetted, and then get it out to people who can use it.
And maybe turn it into a really user-friendly job aid. Okay, well, again, if there's any final, we can take one more comment from the phone, I think, and then just wrap it up for the day.
Hi, this is Deepa Rajamani from Pop Council. I had a quick question. Thank you to all the presenters if they're still online. This is regarding the price tracking for pregnancy test kits. How did you actually use the price data? Did you extend it to assess affordability as well? I know the scope of the study was just to assess availability, but how did it inform? Did you extend it to look at affordability?
So I'm not sure I fully understand the question, but we definitely did look at the affordability, the pricing data to clients, and I think this is a rapid assessment over the past 7 months. So we looked at what the price to clients were across the facilities in the private, public sector facilities that we went to in the pharmacies. So I think, again, in my mind, the next steps are better understanding why those markups are occurring, and also perhaps, what the impact is to clients. Does this create a cost barrier where women, give up and go away because of the high expense, or what? So, Deepa, does that answer your question?
Yeah, it does. I mean, it's again, by affordability, I meant looking at the average wage of the mean wage of the overall low-skilled workers. Essentially, just figuring out how affordable the product is to the end user across these three different sectors that you were looking at, and that could essentially inform pricing later on to make it more affordable.
And this is Amy Lynn. Maybe part of that behind your question is also understanding the socioeconomic status of the end users themselves. And so this is the price in dollars, but understanding their relative income, if they're on $1 a day versus $5 a day, what proportion this would make up if they have to pay for it out of pocket. So I think it's a good point to understand more about the end users and how much of a barrier this pricing would pose to them.
And also one thing a limitation of our work was that we didn't collect the full cost of the service at these facilities to say, if I went into one of these facilities to get an injection or a re-injection, how much of that would be, what percentage of that would be the pregnancy test. And I suspect that actually we would be surprised at how much of that cost would be the pregnancy test, which again I think is not where we want to be and is the problem moving forward that we hope to address as we look at market shaping interventions and discuss that more.
Yeah, absolutely. I think it'll be a nice extension of the work that you've done. But great work. Thank you.
Great. Well, if people voting with their feet is any indication, we still have about over 30 folks still on the line as we go over here. So I just really appreciate the robust nature of this discussion and all the questions that were raised, and thanks to my co-presenters and again to Reproductive Health Supplies Coalition and to this, we still have a number of project team members from all the projects who are on the line, so thanks to their contributions as well. And we look forward to continuing this discussion. All right, thanks again, everyone.